Hi everyone, I'm Dr. Jyotsna. I will be talking about massive hemoptysis. Hemoptysis is expectoration of blood from lower respiratory tract. Means if there is a blood coming from upper respiratory tract, it is excluded from the definition of hemoptysis. It is generally a self-limiting thing, but in fewer than 5% case, it could be massive. So, what is the definition of massive hemoptysis? There is no clear-cut volume which has been mentioned in every book or every guidelines has got its own amount. So, there is no clear-cut amount which says that if this is the amount, it is a massive hemoptysis. Some books are quoting 100 ml and some are quoting 1000 ml per day. Some are quoting greater than 100 ml per hour is massive hemoptysis, but we can just take it that any volume that is causing life-threatening airway obstruction or blood loss is a massive hemoptysis. So why it is dangerous? It is dangerous because greater than 400 ml of blood in alveoli can leads to asphyxia and death. Patient generally dies due to asphyxia rather than because of hemorrhage. A mortality rate goes up to 50% in case of massive hemoptysis. Risk of life depends upon the patient's uh, cardiovascular reserves, ability to protect the airway, and the amount of and speed of hemoptysis. So what to do? Of course, we have to secure airway, breathing and circulation. At the same time, we can lateralize make the patient lie on the lateral decubitus position with the affected side on uh, towards the floor. So how to manage airway and breathing? The main objective of airway and breathing control is to prevent asphyxia and control the airway. Uh, we have to be ready with the difficult airway kit. Suction should be in place. We may need rigid bronchoscopy. That will be the ideal thing instead of going for direct laryngoscopy. If we are going intubating with the direct laryngoscopy, we should section should be uh, uh, catheter should be there because we may not able to see anything. Then maybe we on laryngoscopy we may only get blood and blood. So for intubation, we have to do isolated lungs ventilation. So that for that we will need a double lumen ET tube. But if we don't have single lumen ET tube, can we advance to the healthier side and so that the gas exchange can be continued? There is a Fogarty catheter which is placed through the bronchoscopy, and it is used to separate the unhealthier lungs from healthier lungs or to make the tampona. You can make it like an endobronchial block. SpO2 has to be maintained above 92%. So what is isolated lungs ventilation? As I have already told you, it is to separate the two lungs from one another so that the blood is not get aspirated to the healthier side. So double lumen tube has got its own benefit and advantage and disadvantage. At the same time, the what we have to do, we just have to negotiate further to the healthier side. We have to intubate the healthy main bronchus. Suppose as in this case we can see the right side of the lungs is bleeding, so we have negotiated the uh, ET tube to the main bronchus. So in this way we are separating the two lungs, doing the isolated lungs ventilation, and so the gas exchange will not get hampered. Another way, suppose there is a bleeding in the left side. In that case, we can't negotiate the single lumen AT tube to the right side, because if we do that, we may occlude the right upper bronchus, and because of that, there may be right upper lobe collapse. So in that case, in this side, we just keep a tracheal intubation. We do the tracheal intubation, and we use a Fogarty catheter, which we negotiate into the uh, left main bronchus, and we can make a endobronchial a block by inflating the Fogarty catheter. And if we are lucky to have a double lumen ET tube, we can simply it has got two lumen basically. You can see there is one lumen which goes into the trachea, another lumen it goes into the uh, and we generally intubate to the unhealthier side so that we can also negotiate bronchoscopy probe through it, and we can do the manipulation as required. So this is the through this we do ventilation to the healthier lungs, and through another uh, bronchial lumen we do suction, or we insert a scope, bronchoscopy scope, and we do the maneuver whatever is required. So Fogarty catheter can be placed by through the fiber optic bronchoscopy suction lumen. We can go through that, and we can reach to the bleeding source, and that area can be just tamponade. So how to control circulation? Uh, it has to be done in the universal manner. We have to put two wide bore cannula or central venous line, arterial line as required. IV fluid has to be rushed. Blood group cross matching has to be done. Urgent blood transfusion if required. Till the group specific blood is available, we can give O positive blood to male and non-childbearing age female, and O negative blood to the childbearing age female. We have to correct the coagulation, and we have to give antifibrinolytic like tranexamic acid and aminocaproic acid. So we should know the cause. Most frequent cause which causes hemoptysis are bronchiectasis, tuberculosis in India, fungal infection, and cancer. So cause of hemoptysis from small vessels are immunological or vasculitis disease, cardiovascular disease, coagulation disease, or others other diseases. Uh, Immunological and vasculitis disease, in that Goodpasture syndrome, Behçet's disease, in cardiovascular mitral stenosis, coagulation derangement, iatrogenic if the patient is on anticoagulant, or other like pulmonary hemosiderosis, tubercular sclerosis, diffuse alveolar damage. Cause of hemoptysis from the large vessels are infective cause, cardiovascular disease, congenital disease, neoplastic disease, vasculitis, and other like drugs, foreign bodies, iatrogenic. In infectious disease, abscess, bronchitis, it may be chronic or acute, bronchiectasis, fungal infection, parasitic infection, pneumonia, tuberculosis, non-tubercular mycobacterium. In cardiovascular, arteriovenous malformation, bronchial artery aneurysm, bronchiovascular fistula, congestive heart failure, pulmonary embolism or pulmonary infarction, pulmonary hypertension, right-sided endocarditis, thoracic aortic aneurysm. There's many disease, congenital disease like cystic fibrosis, pseudosequestration, pulmonary artery arteritis or stenosis, neoplastic disease like bronchial adenoma, lungs metastasis or primary lungs cancer, vasculitis disease like Behçet's disease, lupus, pneumonitis, Takasubo arthritis, Wegener's granulomatosis, COPD. Some drugs can cause hemoptysis, foreign bodies. So where this bleeding is happening? So 90% time, bronchial artery is the culprit because it's a high pressure artery. Pulmonary artery is in the another 5%, and non-bronchial artery is another 5%. So we need to find the source, and if we are thinking it's a bronchial artery, we have to see for the origin of the bronchial artery, because in 30% cases abnormal origin has been seen, and if we don't see beforehand, before going for bronchial artery embolization, if we don't see the origin of the bronchial artery, we may do a wrong bronchial artery embolization, and we may be which may leads to treatment failure. The sad thing is that in 3 to 42%, we are not able to find the cause of hemoptysis, and these are called cryptogenic hemoptysis. If we are not able to find the cause and the patient is young, or there is no comorbidity with the patient and patient is smoker, it is said to be smoking related hemoptysis rather than cryptogenic, because uh, tubercular-induced bronchial wall inflammation is one of the reason which can cause hemoptysis in smokers. History will generally guide us to the source of bleeding. Hemoptysis versus hematemesis, that can be done by taking the history and doing the small examination, like there is a sputum is frothy of if there is a respiratory symptoms, or if the blood is alkaline in nature, it is because of hemoptysis. If hematemesis is there, there will be GI symptom and the blood will be acidic in nature because of the gastric acid. If there is epistaxis, you will be able to find blood in the oropharynx. Rhinoscopy can give a more detailed picture. General investigation, we have to send, like we have to do ABG to see for any hypoxia or airway acid base balance. CBC will tell us about thrombocytopenia, anemia, and any leukocytosis. Kidney function test will tell us whether the patient is CKD or any platelet dysfunction, because of which there could be some any platelet dysfunction. We have to give dye, so we should know that okay, the patient is having any kidney function abnormality, so we can prognosticate to the attendant accordingly. Liver function test and coagulation profile needs to be seen so that it can be corrected. Urine analysis may be required for if we are thinking of vasculitis, like good pasture syndrome, to see for any cast in the urine. D-dimer can be done for low probability pulmonary embolism suspicion cases. What are the diagnostic modality? Uh, just X-ray, as it is available, easily available. We can do that if we are not to waste time, but we can just do to lateralize the uh, side of the bleeding, and mm, but if it comes negative, we don't have to rely on it because it is less sensitive for hemoptysis, and we have to confirm it with other modality. Multi-director CT scan is the main modality for diagnosis of hemoptysis. We give contrast material which helps us in evaluating the lungs parenchyma, airway, as well as the thoracic vessels. And the advantage it is that where the bronchoscopy scope can't go, uh, the CT scan can take all the image, and it will be multi-director, and small slice will be taken, so it will gives us as the detailed imaging of the airway, as well as the parenchyma, as well as the thoracic vessels. The limitations is generally endobronchial lesions, like whether it is blood or whether it is tumor or what it is, that is sometimes difficult to differentiate. And so the combination of a CT scan with bronchoscopy is a better choice. So here you can see how multidirector CT scan so diffuse or focal pulmonary hemorrhage. And this is the diffuse pulmonary hemorrhage, which is shown as the perithyroid ground glass opacity, and this is a focal hemorrhage. Hemorrhage along the this is the mass lungs marks and the hemorrhage uh, around the lesion. This is the alveolar hemorrhage. It is in the alveoli and single focal lesion. Here you can see unhealthy area of unhealthy pulmonary area, and this is the bronchus in endobronchial lumen. You can see some yeah, some uh, materials which is basically blood in the endobronchial lumen. Instead of going for multi-director CT scan, we can go for multi-director angiography because it gives us the mapping of all the artery in the thoracic cavity, along with the all the goodness of the multi-director CT scan. That is, we are will able to see the lungs parenchyma. We can see the airway, and at the same time we can do the arterial mapping. The arterial mapping is basically we can see the origin of the artery, its course, where it is bleeding, where it is hypertroph, where it is tortuous, from where it is origin, uh, so we can accordingly plan our treatment. Before going for bronchial artery embolization, it is very important also to see where is uh, where is the origin of interior spinal artery. Normally it originates from T9 to T12 of the descending aorta, and but if it originates above T7, then we should not go for any bronchial artery embolization because it can cause uh, spinal cord infarction and paraparesis. What are the features of bleeding source? If the bleeding vessels there will be extravasation of the dye, you will see visualized tortuous vessels or increased caliber. You can see aneurysmal dilatation of the vessels. The we should go for the all thoracic vessels mapping should be done, that is bronchial, non-bronchial and pulmonary artery, because if one is we are not able to find bleeding from one, it could be some other vessels, because as there is hemoptysis and it is massive hemoptysis, so there should be some one or other artery bleeding, so we should not go for only one artery angiography. We should go for all the thoracic artery angiography at the same time. Pre-embolization multi-director CT angiography helps us in minimizing the any complication, decreases the procedural time, decreases the iatrogenic risks of searching for the abnormal vessels. It decreases the minimizes the contrast and fluoroscopy radiation load time for both patient and the operator. So how it looks in angiography, how the vessels look. Hypertrophied vessels will look like a clusters of enhanced nodules. See, enhanced nodules. It is looking like a cluster of enhanced nodules. And in the three-dimensional picture, you can see the course of the bronchial artery. You can see the tortuous vessels, hypertrophied tortuous vessels here. Digital subtract imaging. It does not give a detailed mapping as a multi-director CT scan, and but one thing it helps in showing the thin caliber spinal artery, which sometimes we are not able to see on multi-director CT scan. Bronchoscopy. When to go for bronchoscopy? It should be done after CT scan until the patient is too sick to be taken out of ICU for bronchoscopy. Rigid versus fibro optic flexible bronchoscopy. Rigid bronchoscopy can also help in controlling the airway, but it requires general anesthesia, that is paralytic and sedatives. whereas fiber-optic bronchoscopy is well tolerated, and it may be just with the help of small sedation. It can be the bronchoscopic is easily tolerated by the patient, and we can use it without any uh, general anesthesia. Localization of the site of bleeding through bronchoscopy is generally around 65% in case of massive hemoptysis, and in around 45% in case of mild hemoptysis. But generally, massive hemoptysis hinders the view because of the blood in the lumen. Bronchoscopy scope can't go till the distal end of the airway, so we will not able to see the distal most end of the airway, which we can see in the multi-director CT scan. We can't uh, understand the underlying cause of the bleeding in the bronchoscopy, which we can understand, which we can able to see or diagnose through the multi-director CT scan. The good thing is that we can take a bowel sample and we can send investigation accordingly. Like if we are suspect, we can send for cytological examination, malignant cell, and we can send from gram stain, AFB, gene expert, TLC, and fungal. We can do fungal bacterial cultures. Therapy that could be done through the bronchoscopy. We can install cold saline or adrenaline. Temporary therapy with oxidizing regenerated cellulose mesh can be done. Endobronchial balloon tamponade can be done with the Fogat catheter, which we can introduce through the fiber optic bronchoscopy or through the rigid bronchoscopy. Through its suction channel, the Fogat catheter can be negotiated inside, and it can be placed at the bronchus, which is causing bleeding, and it can cause the tampona effect. At the same time, it can isolate the lungs, uh, this unhealthy lungs from the healthy one. Treatment: endovascular embolization is the current effective and most minimal invasive procedure for treatment of massive and recurrent hemoptysis. It could be taken as a definitive therapy, or it could be used as initial stabilization for before a surgery. Embolization reduces the pressure in the fragile hypertrophied artery vessels supplying the pathological lungs area, and decreases the risk of peri or operative bleeding. Complication of bronchial artery embolization. The most devastating complication is paraparesis because of spinal infarction, because of anterior spinal artery embolization. Vessels perforation, intimal tear, chest pain, pyrexia, hemoptysis, and systemic embolization are the other important complication of bronchial artery embolization. So here you can see this is the extravasation of the blood from the bronchial artery circulation, and here the embolization of this abnormal left-sided bronchial artery has been done, and now there is no bleeding or extravasation is happening. Surgical resection is only done in the refractive cases, like repeatedly other therapy has been done and which has got failed, or there is a local bleeding going on. In that case only surgical resection is done, like for chest trauma or iatrogenic pulmonary artery rupture, or leaking aorta, or aneurysm, or there is a arteriovenous malformation or Hardity cyst in these cases, and it is refractory to other treatment, we go for surgical resection. The mortality range from 1 to 50%, and patients should be able to tolerate the surgery. Then only we can go for that. Surgical surgery during acute hemorrhage has high risks of complication, high mortality rate ranging from 7 to 18%, and it may increase up to 40% in the case of emergency surgery. Pharmacological therapy depends upon the cause. If there is infection, we can give antibiotic. If there is fungal infection, we have to give antifungal. If we are if the cause is vasculitis or uh, immunogenic cause, we have to give steroid. If there is a problem with the coagulation abnormalities, we have to give anticoagulant. Summary of the diagnostic modality and the treatment. Whenever there is massive hemoptysis, chest X-ray and multi-detector CT scan is done. If we find something in detector CT scan, if there is chest trauma or iatrogenic pulmonary artery rupture, then we can go for surgery. Otherwise, for all other case, we go for uh, endobronchial embolization. If we are not able to find anything on CT scan, we go for a bronchoscopy. In bronchoscopy, if we are able to find the bleeding point, we again go for uh, bronchial artery or endobronchial embolization. And if we are not able to find anything on bronchoscopy also, and there is a massive hemoptysis, we will call it as cryptogenic hemoptysis. These are the references. Thank you.